Hi, everyone. Welcome to today's webinar, Thoughts about Suicide, Understanding CBT and Suicide Prevention. We'll get started in about 3 minutes. Man. Hi, everyone. Welcome to today's webinar. My name is Travis Atkinson, and I am a board member for the Crisis Residential Association and the chair of the Training and Education Committee. It's a pleasure to have you here with us today for our webinar, Thoughts about Suicide, Understanding CBT and Suicide Prevention. This webinar is brought to you by the Crisis Residential Association. We are a nonprofit 501c3 organization advocating for humane alternatives to psychiatric hospitalization. You can learn more about us at crisisresidentialassociation.org. You can also follow the conversation on social media and follow us on Facebook, LinkedIn, or Instagram. Also coming up is the National Crisis Continuum Conference, October 5 to 8 in Atlanta, Georgia. More information is available at crisiscon.org. And if you'd like to join us, we'd love to have you as a member. You can become a member of CRA. We'll talk more about that at the end of the webinar. And we'll also talk about our upcoming webinars, which we offer every other month. So our next one will be in July, and they all happen on Wednesdays at 1 o'clock. And lastly, we're excited about our Crisis and Coffee sessions that we'll share more about as well as a way for members to connect. So with that, I would like to welcome today for our conversation Leo Kerr. Leo works at the Harris Center, which is located in Houston, Texas. He is a trainer with a vast amount of experience in training on behavioral health topics, and we're very excited to have him with us here today. And before, Leo, you start, I'll just mention also that we will be recording today's webinar. The recording is made available immediately for members, and then a few weeks after the posting for non-members. So if you'd like access to the recording, in a quick and timely fashion, that's another benefit of joining CRA. So with that, I will turn it over to Leo. Leo, welcome.
Thanks, Travis. Welcome, everyone. I appreciate you joining us for the training. Let me give you guys a warning. I think that if I do this right, there probably should be some triggers for self-harm, suicide, grim stuff. And just as a heads up on that, I wanted to talk to you guys a little bit about a cognitive behavioral therapy informed discussion about suicide prevention. I have an idea for an activity to get started. Hopefully this works. For The first few slides, I'd like to just do kind of introduction, setup, a little bit of flavor. So if you could get a piece of scratch paper or a Word document or something you can write on. I'm going to share a word with you, and then I want you to write down the first five other words that come to mind. If you're doing this right, it shouldn't take more than 10 seconds. So make sure you get a scratch paper or a Word document so you can just jot down the first five words that come to mind. So here I am. I'm going to share this screen with you, and it has a word on it. And then just jot down the first five other words that come to mind. The word is suicide. When you see this word, what are the first, just don't even think about it, the first five things that come to mind? Any other word? Jot it down real quick. Okay, that's 10 seconds. So you should have written down five words. Doesn't matter what they are, there's no right or wrong answer. I'm going to explain why we did that in a minute. Um, to start out with, I think about Bloom's taxonomy more than I probably should. And this is a look at knowledge, right? Trying to understand and apply knowledge, but then analyzing it, evaluating it, and at the highest level, trying to form a new coherent functional whole. And one of the problems that I've had with some of the suicide prevention approaches have been that, they seem kind of like, I don't know, basic, showing like an application focus, but not necessarily like a level of understanding and adaptability to it. And I'd hope to look at that in this training. To start out with, um, okay, I found an artificial intelligence program that listed these six standards of valid crisis intervention. So you can pay money to this artificial intelligence vendor, and they'll rate your employees on emotional de-escalation, risk assessment, active listening, protocol adherence, empathy and validation, and safe resolution. Now, maybe this is an amazing program, but I'm going to take this as a baseline, right? These are things we can do better than. And so we can probably do better than this artificial intelligence at suicide intervention as crisis people in mental health. And let's take a look at how. I don't necessarily have all the answers, and so I am welcoming any feedback and input from you guys. So, okay, to start our journey, I looked at this artificial intelligence, but I also did a Google image search. And I was just trying to get a sense of the flavor of suicide prevention. And these were the top Google image search results for suicide. I think that what I took out of this is it gave me some cultural context. This is awfully grim stuff. All the images are black and white. Several of them are literal stop signs. It's almost, to me, seemed kind of abrasive. And it made me think about our messaging on suicide prevention. How do we inspire people? How do we engage them? And if I was on the computer or scrolling through social media and I saw a black and white image of someone's face disintegrating into nothing, and I might think, well, I don't know if that's the vibe I want to go for. So this first part, let's look a little bit at our vibe and our attitudes and our kind of approach to suicide prevention. What is the significance and our preconceptions about suicide before we really go anywhere? Okay, so we started out with this word association activity. You guys saw the word suicide and wrote down any five words that came to mind. There's no right or wrong answer. What do you think about suicide? And so if you look at your list of the five words that you came up with, they can really be anything. Do you notice any patterns or any trends? Take a minute maybe to reflect on what came to mind when you saw the word suicide. Um, and just think for yourself, what is the pattern there? Was it cautionary? Was it inspirational? Was it random? Um, let me share with you guys a few of the word association things to you might consider looking at these five words. So I've tried to base this on studies, and one of the things is that absolute words like complete, total, permanent may constitute a specific suicide intervention viewpoint versus language as temporary. The idea is that maybe someone who is suicidal will see things in a more permanent way rather than in a more temporary way. I don't know if that hits on any of the 5 words you put on your personal paper, but that may be something to look at if you had a tendency to link it more with permanent or temporary things. Another way associations with the word suicide tended to vary was being collectivist or individual. Is it, they did a study of suicidal poets, and they found that non-suicidal poets used more collective group words, us, together. And then suicidal individuals tended to be more detached, more, it's, personal, it's just them. And so, looking at potentially text analysis of the way people like associate things with suicide, is it together? Is it alone, individual? That may be something to consider in the 5 words you selected. The other, there's 4 things here. The third is that words impact our worldview. And they did a study and they repeatedly exposed people to words accident, murder, and they found that whatever exposure people had, rendered their view of suicide in a different way. So if someone's repeatedly told about accidents and then something happens resulting in death, they're more likely to see it as an accident. And that shows that whatever came before really affects our view of suicide. Context matters. Previous held views and word use impact perspective. So when you look at the 5 words you chose, which no right or wrong answer, um, how do those associate with like your previous worldview and previous experiences? And then the last of the 4 elements to consider with this word association is that some studies showed limited or no relation between words and suicide context. So that might be a little bit of a gotcha, that maybe it's all random. Maybe whatever 5 words you chose has no meaning. And the idea that suicide can't be predicted by other things might be important later on when we talk more about suicide specific processes. So um, give that some thought, the 5 words you chose. Um, and what, if anything, it might say about your view on suicide. I would like to share with you guys some other words. These words are ambiguity, preventability, stigmatization, and trauma. These are characteristics that family members of someone who committed suicide associated with the death of their loved one. Um, so the deep emotional significance of this death by suicide in the study was seen as a choice by the deceased, which created the unique dilemma for their loved ones of ambiguity about the volatility of the deceased. I mean, why did they kill themselves? I thought they were doing okay. The preventability of death, it might have seemed like there were other options. The stigmatization that maybe people looked at them or their family differently, and then the trauma of a self-inflicted death. Some studies have suggested loved ones of someone who completes suicide are themselves more likely to attempt suicide. So I wanted to start out with a little bit of this social flavor of how do we see suicide? How does the culture that we live in view suicide? Let me share with you guys some statistics, because if we're going to take a wide view of things, society and culture, in 2023, over 49,000 people died by suicide. That's one death in every 11 minutes. Now, some subcomponents of that are important. 12.8 million people seriously thought about suicide. And then about 1/4 of those people, 3.7 million, made a plan for suicide. And then out of those people, 1.5 million attempted suicide. So what that means is that about one-fourth of people who think about suicide make a plan, and then about 10% or so of people who think about suicide attempt suicide. So what does that tell us? Um, I'm going to summarize and pause for a minute. If anyone has any questions or comments, please use the chat. So this first part, consider your reactions to suicide. Countertransference is unavoidable, but probably helpful if studied, which was the word association. The culture around suicide seems like it's marred in problems, focused on stigma-riddled, grim stuff like the Google images. Um, and interventions surrounding suicide can seem routine or robotic. There's even artificial intelligence that will contribute or rate, suicide prevention measures. And then let's look at ways of innovating and experimenting, but making sure people are safe. So to pause for a minute, here's this abstract image. Suicide is Painless by Amy Ramsey, to go with this idea of how do we imprint context on our view of suicide prevention. I'm going to quickly check the chat, and I'm not seeing too much. Feel free to make comments in the chat at will if any questions or comments. I'd like to transition a little bit to the next part, looking at cognitive processes in suicide. So, like, what are some of the theories that explain how people become suicidal? So, one of the principles that guides any discussion is safety first. Healthcare is to be life sustaining. As crisis workers, we're the safety net that people land on that make sure that people are alive. But how can we do better than that? So here is a graph. If people are suicidal, a lot of times they're reviewed for emergency detention. And one of the problems that I've had with suicide prevention is that it's almost like, hey, let's get people to an emergency room or kind of assume that they're okay. It's an absolute all or none, sometimes trap that we get stuck in. So I added a clown image to this just to defy the typical of like if we're filtering people into categories, taking such an absolute approach is life sustaining, but may not be as clinically helpful for intermediate cases. So I'll build on that. It's kind of like a trampoline. We don't want to turn our safety net into a trampoline where people aren't falling, but they're just jumping up and down and up and down, and they can't get out of the safety net. They can't jump off the trampoline. So how can we turn short-term safety into long-term gains? I would like to ask you guys, what helped you the last time that you felt suicidal? Just think about that for a minute. We're going to follow up on this slide, but what helped you the last time you felt suicidal? Now, that's kind of bleak, but this is less bleak. Cups of Hope. I don't know if anyone is here from Tennessee, but Tennessee had a great initiative called the Cups of Hope. And September 2025, just last fall, they partnered with coffee shops and they had a contest where people drew inspirational, uplifting messages on coffee cups. And then if anyone went to a coffee shop, they got a cup of hope with suicide prevention resources and a little bit of encouragement, right? Because we know in 2023, 12 million people considered suicide. So out of a random coffee shop, they're going to hit some people who need help, who need hope and encouragement. Coffee is important. That might be kind of a weird device, but I'd like to use coffee as a device to inform our discussion, and I'll explain that later. So, what helped you the last time you felt suicidal? Think about that. Now, if you immediately recoiled to respond with denial, well, I've not been suicidal, I don't have that problem, then that might suggest its tendency towards seeing suicide as stigmatizing or divisive. I'm not like them, we're different. Consider the basics, right? Like, I don't expect many mental health professionals are suicidal, But let's break it down into some building blocks because part of this is to defy the all or none kind of viewpoint of suicide. And if you look at it in terms of behaviors, right? Like, what are things that we've done that are self-destructive or self-defeating? Maybe not outright suicidal, or emotions. Last time we felt feeling sad or overwhelmed. Our thoughts, like hopeless, that maybe we don't belong. Let's look at this more clinically. So for the next few slides, I'd like to look at the building blocks of self-harm, some of the theory that informs what might contribute to people feeling like they have self-harm. Um, and so I find it helpful to look at suicide or self-harm as a continuum, that it's not all or none, that, in a way, everyone is on this suicide continuum. And so at the darkest, most extreme is suicide completion, suicide attempt, self-injurious behavior with unclear intent, and then going towards least concerning is suicidal ideation with a plan, which we know is about 4 million people. Suicidal ideation without a plan, which we know is about 12 million people. And then kind of at the other extreme is this passive death wish, like, I'm tired of life, I'm not going to kill myself, but I guess if I died naturally, I feel like I'd be okay with that. Um, so I want to normalize the idea that people have fleeting thoughts of death and suicide. With mood disorder specifically, recurrent thoughts of death and suicide are normal. So I assume they're present to some degree in anyone with a mood disorder. Um, People are 10 times more likely to think about suicide than to attempt it. So even for people who aren't acting on this behavior, it's a thought in their head, and we're going to develop on that. And then 3 times more people plan suicide than attempt it. So that means that people who maybe never go to an emergency room are thinking of suicide, or maybe even have a plan that they don't attempt. And so they don't initiate this crisis safety net. Um, okay, so let's oversimplify suicide prevention. One way to look at suicide prevention is protective factors versus risk factors. So if someone's protective factors are stronger, then they're less likely to think about or engage in self-harm. And if their risk factors are stronger, then maybe they're more likely to. And these represent ways to intervene. So protective factors is literally anything that makes it less likely someone will will struggle. So it could be things like a pet, spirituality, contact with other people. It could be a coffee cup from the Tennessee Cup of Hope program, connectedness to individuals, availability of healthcare, literally anything. Um, Risk factors are anything that make it more likely someone will struggle. So not all risk factors are equal. And the important thing is that risk factors are not warning signs. They don't cause suicide. But we know that if someone made a past suicide attempt, that makes it more likely they'll attempt in the future. Access to lethal means, mood disorder, substance use. Now, it's important that these don't cause suicide, but they maybe make it more likely. SAMHSA has a clever acronym, is path warm. And so these are warning signs for suicide suggested by SAMHSA: ideation, substance abuse, purposelessness, anxiety, being trapped, hopelessness, withdrawal, anger, recklessness, mood change. So, okay, we've talked a little bit about the context suicide's in, and we've talked about looking at it on a continuum rather than absolute. And we've talked about risk factors versus protective factors. And so I don't know if anyone here is an Elton John fan, but in 1975, Elton John attempted suicide. He took 60 Valiums, right? Here's a picture of Elton John in 1975, you know, jet setting, fashion. It looks like he's maybe living a life most of us might aspire to have, but um, attempted suicide. So there's an element of that that defies conventional explanation. You know, why would someone who's at maybe at the top of his career attempt suicide? I'm going to check the chat if anyone has any questions or comments. Um, Great. I see some of the comments about the help people got, knowing support, having friends. That's important. That um, grief plays a role. Thank you, guys. Okay. There is a hot oven. And what makes people take their hand away from the hot stove in the context of suicide? So, a lot of times, if we're going to look a little bit at cognitions and risk factors, thoughts evolve to adapt the person to their environment, right? People will develop like viewpoints that protect them in a lot of situations. But a psychological state is never good or bad in itself, only in relation to the context, right? So, using this analogy of if someone's hurt, or someone's like experiencing pain, why don't they just move their hand or get help or change the situation? Here are some things that may play a factor in that. Dispositional risk factors. These are long-standing psychological traits. So, things like these have the potential to interact and increase life stress. They can be associated with psychiatric disturbance, and they can exacerbate psychiatric emotional dysfunction during a crisis. So things like perfectionism, problem solving deficiencies, having an overly general memory style, or impulsive aggression. If someone's a perfectionist, they may be less likely to get help. They may be more critical of themselves. And that might be why someone might say, like, hey, I shouldn't have to move my hand. I should be able to deal with the pain because I'm a perfectionist. They may have dispositional risk factors. Um, there's a theory about capacity for suicide, that capacity is acquired through the lowered fear of death and adjusted pain tolerance. The idea here is that habituation to repeatedly painful or risky experiences makes it more likely people are like, they don't, they're not as sensitive to pain. Life has been hard. You might see things like potentially risk-taking behavior, shoplifting, promiscuity, fighting, and not just explicitly suicidal behavior or thoughts, but people kind of questioning in behavioral ways like, is life or society worth participating in? And what we could really be seeing is that they're developing this sort of capacity for suicide. And that might explain why a previous suicide attempt makes it more likely someone's going to attempt again in the future, or why some clients live hard lives and don't attempt suicide and others do. And again, having a hard life isn't a reason for suicide, it's maybe a risk factor, though. Um, Cognitions and suicide attempters. The important thing here is that suicide is the thing we're looking at and addressing. So people who've attempted suicide have shown higher levels of externalization of self-worth, needing approval from others, labeling, looking at things as being one way or another, comparisons to others. Why are things different for me? And fortune telling, forecasting negative events. Now, these none of these risk factors explain suicide. I like to use the example of a coffee creamer. Now, you could flavor your coffee however you want, the context of it, but the important thing is that we need to look at the suicide. And so we're not working to change people's externalization of self-worth necessarily. We're looking at changing their tendency towards suicide. I'll explain that better, I think, in a slide or two. So, Joiner's interpersonal theory. This is a theory that suicide is associated with dynamic interpersonal and intrapersonal processes of thwarted belonging, perceived burdensomeness, and hopelessness. So, this theory is that if people feel like they've tried to belong and it got messed up, it didn't work, or they feel like they're a burden to people and they feel hopeless, then that makes it more likely that they will attempt suicide. To build on that, thwarted belonging. This is an affect-laden cognition that has that people have too few social connections and resulting in an unmet need of social connectedness, loneliness, and absent of reciprocally caring relationships. These are clinical issues to consider in general as we engage with people who may report suicide or who we have concerns about. Perceived burdensomeness, the perception of liability. It's often something we can modify in therapy. So there's two dimensions. One is the belief that someone is so flawed, they're a liability to other people. Everyone's having to take care of me. I'm so broken. I can't do anything right. And then the other part is this affect-laden cognition of self-hatred. So this is something like the mental context of what we might see with people who have elements of suicidal thinking. I want to transition to let me share this next slide with you. I wish I had a better transition, but okay. The important thing to keep in mind is despite all of this, suicide involves suicide specific processes. So suicide is its own thing, right? There's cognitive processes associated with suicide. The important thing is that it's not that suicide is the final boss of being sad. It's not a continuation of financial difficulty. It's a unique and independent thing. So if we try to address people's other problems, we might be missing the goal of intervening on suicide. So there's stress and predisposition, which impacts general dysfunction and psychiatric disturbance. Someone might be depressed because their genetics or because of stress and their life experience. But that doesn't mean that they're suicidal. And then, totally separate from feeling depressed, someone might feel suicidal because of their disposition and their stress. And the cognitions with emotional disturbance and the cognitions with suicide can interact with one another. But the important thing is that they're separate. Suicide acts are based on suicide cognitions, not general cognitions or general pathology, which might be why someone like Elton John, who seems to have a lot of the things people might aspire for, could still feel suicidal, because he doesn't necessarily have psychiatric disturbance, but he has cognitions and processes associated with suicide that never get addressed, maybe because people assume he's okay. So this is a slide to emphasize that suicide is its own thing. It's not caused by something else. Um, Other issues like mood, beliefs, personality can interact with suicide, but they don't cause harm behavior. So it's important to directly focus on suicide. Hey, I don't know if it's anyone's birthday today, but this is a birthday present. And a thing that's in this birthday present, a birthday present is rarely just a birthday present because, with a birthday present, there's balloons, there's friends, there's candles, there's songs, there's birthday cake. There's a whole blueprint of everything. At least I find it hard to just think of a simple birthday present without also thinking of birthday hats and friends and candy. It comes as a package. And this is an example of a mode. So a mode is an interconnected network of thoughts, emotions, motivations, physiological reactions, and behavioral ideas that are activated simultaneously by so the idea here is that people will go 0 to 60 because they're not just moving in a path on a single line. That if you see something like a birthday gift, then all of a sudden it triggers all these flashbacks and ideas and history as a bundle all at once. And that that may be one thing that contributes to suicide, that there's a suicide mode. And so the patient might experience suicide-related cognitions, negative effect. It's cascading in rapid succession. And that might explain why, well, the client said they were okay, but then suddenly they've attempted suicide because this bundle of suicide ideas, which we've said is its own thing, right? There's a suicide mode lurking underneath the surface. And how can we unbundle that and put interference between the point of suicide activation and the suicide mode? Um, Dr. Jekyll and Mr. Hyde, for example. It might feel like two extremes of the same person. You know, the client was okay one day, the next day they're just totally different. Dr. Jekyll is fictitious, but we might see this in some clinical presentation. Change is not smooth, linear, or continuous. It's non-continuous and chaotic. That it's not necessarily incremental. So, you know, there's an element of chaos that we see with things like the mode. So here's an illustration of chaos. And I wanted to pause to see if anyone has any questions or comments. I see there's one thing in the chat about artificial intelligence assistant. We don't have to worry about that, I guess. Well, hey, thank you guys. I'm going to transition to the next part, which looks a little bit more at interventions. Someone mentioned that grief is also like this chaos. A lot of things are. Um, as an illustration of that, here's a suicide letter that was written by a child. And fortunately, this person was able to get help. But you can see a lot of these cognitive ideas in this, um, explaining, that I wanted to do this to myself. Don't be mad. You know, I I don't need to live. And these are a lot of the unspoken things that as clinicians, we would work to try to get verbalized and to be able to address. Um, so, quick summary: safety first. We want to make sure people are safe, but assuming they're safe, recurrent thoughts of death and suicide are normal. And so, looking at the continuum of harm, it's not all or none, and that we might assume a lot of people come to us really feeling crummy and suicidal, and that's normal. Things to look at in terms of cognitive variables are thwarted belonging, perceived burdensomeness, and hopelessness, which might play a role in this capacity for suicide, the lowered fear of death and heightened pain sensitivity, and that there's a term called the mode that looks at this interconnected bundle of emotions and thoughts that all happen simultaneously that might explain the non-continuous nature of change. That suicide is a primary problem to be addressed directly, not as a continuation of other issues and hardships, and that even though there's co-occurring cognitive patterns, they don't necessarily explain the suicide and the view of harm risk. Okay, so we're doing good on time. I think we have about 20 minutes left, which is about where we need to be. I wanted to share some general interventions for everyone about suicide intervention. So for cognitive behavioral therapy, sometimes idea is that you need to be like a therapist to really engage people. But I wanted to make sure with this training, I'm including elements that are general that anyone could really do. Um, so a reminder that suicide is the primary problem, and it's not a symptom of something else. It's appropriate for wide ranges of psychiatric disorders. And we want to look at unhelpful thoughts and behaviors specific to suicide. Um, the other principle is to be present focused. And so with that is that we want to look at the the most recent episode of self-harm, the circumstances at the timing of that episode. So to be as specific and present to the index event as possible, and not just in general. So general interventions, gatekeeper training. Individuals who regularly interact with a client population should be trained to recognize warning signs and respond appropriately. One thing that is helpful is mindfulness. And I'll give you guys some examples of mindfulness interventions. Paying attention in a particular way on purpose in the present moment and non-judgmentally is something that has been shown to help people who are in crisis. Looking at resiliency focused interventions as a strength-based approach, how can we build resiliency rather than maybe focus on the self-harm? Um, and then also looking at like wraparound services. So with family and supports, making sure that we improve people's ability to be with our client. Teaching parents and family members to listen, maintaining connection, being compassionate. How can they trust their judgment and prioritizing safety? So making sure we're networking with their collaterals. So with the patient, here are a lot of these are inspired by dialectical behavioral therapy. One approach is to look at comparisons. So when you work with a client to compare their situation with those of other people, and it could be literally anyone. When I was a kid, I used to think, what would RoboCop do, right? Now, I mean, that's a flight of fancy, but it helped me because I'm like, wow, RoboCop would be this way. I could do this. So by comparing myself to maybe RoboCop, or our clients would probably not use RoboCop, but it could be themselves in the past, in the future, who they'd like to be, someone they admire. It's a way to remove the personality from things and just look at how can we change, engaging in change talk. One way to do comparison, because we're looking at extremes, right? In a way, we're looking at extremes, the chaos of feeling overwhelmed, feeling suicidal, feeling like you don't belong, you're hopeless, you're a burden. So the eye of the hurricane meditation is a way of thinking about the problems as a hurricane, right? There's chaos. It's overwhelming. You don't know what to do. You feel out of control. But every hurricane has an eye in the middle. It can be difficult to see the eye of the hurricane at times, and sometimes we forget the eye is even there. However, it is always there. So if we examine closely enough, even the strongest, darkest hurricane, sooner or later we'll see the eye centered and constant. And teaching clients to look at their disturbances in this way introduces the idea of contrast, that no matter how they're feeling, there's something opposite to it in the middle of a hurricane. Um, and that might be something that helps them feel grounded and addresses some of what they're presenting. When in doubt, use senses. So self-soothing with the senses. What can they see, hear, smell, taste, or feel? And so if someone is feeling overwhelmed, a lot of times that is something that will help them feel focused and can help redirect them without necessarily even engaging them on the problem issue. So self-soothing with the senses is an easy go-to. Okay, just a few more kind of general sort of skills approaches we might teach to help people cope. Um, Half smile. I like this because, sometimes people will be like, hey, take deep breaths, smile. But a lot of times I'm like, well, I mean, I can take all the deep breaths I want, but I'm really focused on my problem. And if I try to take deep breaths, it doesn't really take my focus away from my problem. And it feels kind of fake and overly happy, right? So this half smile, and it's where people will relax by, instead of making a full fake smile, you would kind of try a half smile, gently upturning the lips with a relaxed face and having a serene facial expression. The idea is to use your body to communicate with your mind, but a full false smile might tell your brain you're hiding or fakely happy. But a half smile is somewhere in the middle. And that's something that could be effective for people who feel like just the full smile isn't really, it's too fake, maybe. Uh, Radical acceptance. So recognizing and accepting the problem or situation as it is. You don't have to like it. You just have to accept it. So some of these coping statement examples could be: situation is only temporary. This feeling will pass and I'll be okay. I can't change what's already happened. I'm working to make peace with where we're at and whatever the situation. It's okay to feel anxious, upset, or mad. I can still deal with this effectively. So evoking from the client these coping statements and kind of helping them is something that could be helpful. So redundant slide to emphasize that suicide is its own issue, and we want to work to address suicide directly. Now, we've talked a little bit about some general kind of skills. I want to jump to late stage treatment. I'm going to check the chat here real quick, though. And so, okay, appreciate someone else said grief looks like chaos. Okay, visual component, thanks. Yeah, suicide is a permanent situation to a temporary problem. Thanks. Okay, so let's jump ahead. The ultimate goal of intervention with suicide is to address this suicide mode, the suicide activation. It's a threshold at which the cascade of suicide relevant cognitive biases is activated. This depends on part on the person's history, but we want to find a way to stop the activation of the suicide cascade. Keith Hines is I'm sorry, one second. I'm just going to close my door. Okay, sorry. Keith Hines, you guys may have heard of him. He's a suicide prevention advocate. In the year 2000, he jumped off of the Brooklyn Bridge and survived. So since then, he's turned his life around and he goes around giving inspirational speeches to people about suicide prevention. How can we turn our clients into Keith Hines? One way to do that is at the end of cognitive behavioral therapy for suicide prevention is a relapse prevention task. This is guided imagery through the suicide attempt. So what we want to do is to trigger all these problems with suicide. Remember when you felt hopeless. Remember when you didn't belong. Remember when you took 60 Valiums. It serves as a cognitive rehearsal, and it helps the clinician to assess if the termination is appropriate or not. So with the relapse prevention task it's imagine the circumstances of a previous suicide episode and the internal experiences associated with the event to try to evoke the suicide attempt as much as possible. But because it's at the end of the treatment, people will then substitute in helpful skills that they learned in treatment to try to successfully resolve the crisis. And the therapist is on hand to address and to assist. So the reason for this is because with the birthday example, right, there's a state dependent learning, right? And so we need to find a way to get into this sort of suicide mode that might not be readily accessible because most of our clients, when they see us, they're not in acute suicide activation. So we want to find a way to get into the suicide mode and help them apply things that they've learned through treatment at the very end. So as a heads up, this is the ultimate goal of our cognitive behavioral therapy intervention, that they kind of relive through the struggle and they learn to adapt. They learn to use the healthy strategies that they've developed in our interventions at this sort of grim, overwhelming moment. And so, quick overview of the specific treatment processes with cognitive behavioral therapy. Early treatment, identify suicide triggers, review the suicide narrative, do safety planning. The middle phase of treatment is looking at emotion regulation, problem solving, and increasing skill building. And then the late phase of treatment is this relapse prevention task, planning for safety. Okay, so we have about 10 minutes left, which is right on where we need to be. And so I'm going to talk a little bit about early treatment and middle treatment, and then that'll be the point we conclude. So in early treatment, there's a client who's suicidal, they're coming in. We're going to look at suicide triggers and review the suicide narrative and a safety plan. Also introducing them to the cognitive behavioral therapy conceptualization. The long and short of it is we want to fist bump the client. That's it. Be present with the client, be encouraging, just see what's up with them. And that may be all they get out of treatment, right? It may be that we don't continue, that we struggle, that they may not show up, but this is the vibe. We want to just fist bump. Hey, what's up? You're going to be okay. How's it hanging? Kind of thing. And so to start out with, engagement is the only priority. Um, so early on, using consent as role induction. So the language here matters, which kind of goes back to our word association thing. Um, Trying to instill roles. You know, treatment for all these problems has been found to be effective. You should be aware that we will talk about some things that will be very painful for you. One of the primary targets in treatment is the reduction of suicidal behaviors. So using our consent in a specific way. So a lot of times we just use kind of general language. Something to consider might be to look at the language that's used at your agency or in your process when you do intake with people. So early treatment, engagement, orientation, and then developing a problem-solving focus. One of the things to keep an eye out on is smart books. It's a good idea to give the client a book that they can take notes on and to teach them to write a brief summary about what they got out of each session, kind of a memo to themselves. It helps them be active in treatment. It helps transfer the skills. And when we get to this relapse prevention task at the end, they've got this book that just walks them through how they've learned to resolve some of the things that brought them into treatment. One of the things that I found helpful is to ask people, well, what's stopped them from killing themselves? You know, a lot of times this will put the client in a place where they're the one arguing for life, telling you about their kids, their religious beliefs. They didn't want to disappoint their parents. It also validates the thoughts of suicide, and it evokes protective factors. So I like to ask that to people at the beginning of treatment. And then that way I can kind of see what their subjective experience is with what they think is going on. And someone might say something like, well, you know, I always had a guardian angel, and I feel like even though you can't see it, it's like watching out for me. It's a way to get those sort of strengths out there that might go unsaid if we just look at the suicide um, stuff alone. Strategy at this point is the coping grid. Here we are in early treatment, and we want to look at bulking up coping skills. So, you know, here's an example, a variation of a coping card. What can you do when you're alone during the day, during the evening, or if you wake up during the night? And what can you do when you're with others? That way, clients, and that kind of lines up with the smart book. Clients just have an easy thing where they've kind of problem solved some of the things that they would see as helpful. They have a personal crisis plan. Um, so you and the client have talked about in this part of treatment triggers, ways to distract themselves, safe people they can reach out to. It's a brief collaborative intervention. It should take about 45 minutes. And that way the client has this plan. Um, and so what you're doing is you're kind of doing this relapse prevention task without the trauma or the triggers or the problem, just looking at the solution. If you feel like there's a problem again, what can you do? And then as we go through treatment, we learn, teach the clients and collaborate on how to apply this stuff. So here's another example of a safety crisis plan. I picked these examples because they're a little more informal and I think client facing. And sometimes we give out these documents that are just a wall of printed text. And so the client should have something that is relatable to them. Early treatment interventions, identify reasons for living. We talked a little bit about that. Why do you think you're still here? And this might kind of look at like unfinished business. What are things that they've been meaning to do? Why is it important for them to keep living? Um, Early in treatment, the client should write a patient narrative about their most recent suicidal thoughts and behaviors. And this is something that would ideally aid treatment planning and be potentially cathartic. Now, the wording is important here. Tell me what happened on the day of your suicide attempt as if it was a story with a beginning, middle, and an end. Um, I would like to hear about the circumstances, thoughts, feelings, and actions that resulted in your decision to attempt suicide. We're directly engaging them on the primary problem of suicide in a present focused way. We're asking them about thoughts, feelings, and behaviors, and we're asking them to write an end. So that way they're not just dwelling on things, they're telling like a more complete story. That's something that will bring about some of the case conceptualization items. What were their automatic thoughts? What were their beliefs? What were their early experiences? Risk factors. In early treatment, solve. Select a problem, generate options, rate the likely outcomes, choose the very best options, and evaluate. So at the end of treatment, we do a relapse prevention task. Early on, all we need to do is engage. Give them a smart book, look at aspects of retention, and then once we have that, we would do a suicide narrative and the safety planning. Middle treatment, we're going to look more at bulking up skill building, increasing hope and social support, problem solving, emotional regulation, emphasis on coping cards, hope kit, behavioral coping skills. So this is where we go from the general, presenting problem to like building on solutions. A reminder about the working alliance that because engagement is the biggest thing in early treatment, agreement on goals, consensus on task, and emotional bonds constitute the working alliance. And those are things to keep an eye on because we want to progressively challenge people, but also make sure that they're able to cope with it. So here are some examples of the cognitive behavioral interventions, the thought record, evidence for and against, how was your mood in that situation, what are alternatives. Um, there's something called a downward arrow tactic, you know, so what motivated that? And then, so why do you think, so if someone has a belief, you might ask what it means about them. And the idea is that sometimes people give us a superficial automatic thought, and then there's an intermediate belief. And we want to eventually get to overall view, core belief that we can work to challenge. Um, so I'm going to skip a little bit ahead and just point out that and sort of wrap up, distress tolerance is a focus here. We're teaching people to look at distressing situations and to reevaluate them. One of the things I like is if they're blaming themselves, the responsibility pie. What percentage of responsibility do you have for this situation? And what are other factors? And what percentage of responsibility do they have? That way, if someone has some of those dispositional risk factors like perfectionism, it teaches them to look at like, well, maybe I messed up, but I'm 30% at fault and not 100% at fault. Um, One of the ways to look at distress tolerance is the ability to handle feeling distressed, how impactful the distress is, the focus on distress, and then also the key here is attempts to mediate distress. It's okay to feel distress, but what are people doing to mediate their distress?
Leo, we are coming right up to the end of time, so we're going to have to wrap it up. But I want to thank you so much for your presentation today and for the information. Unfortunately, we don't have enough time for questions,
Hmm.
but we did get one question in the chat. I've just asked that that person send us their email address. I have one thing that I want to share before we end our time together today, and that is a little bit more about our crisis and coffee sessions offered by CRA. I just want to give a quick update. Crisis and Coffee is going to replace our current monthly membership calls and offer a more informal, peer-driven space for CRA members to connect, share, see what you're seeing in the field, and stay engaged with CRA updates. Each session is just 30 minutes and will follow a light structure, a quick check-in, open discussion, peer input, and a brief close. The goal is connection, conversation, and learning from one another. Our first two sessions are scheduled for Tuesday, June 16th at 9 a.m. Pacific, 12 p.m. Eastern, and Thursday, June 18th at 3 p.m. Eastern, 12 p.m. Pacific. We'll have sessions in July as well. So look on the listserv for those updates. And if your organization is a member but you're not on the listserv, just send an email to myself, Travis at crisisresidentialassociation.org, and we will get you signed up. So, Leo, thanks again for being here. Thanks everybody for attending, and we look forward to seeing you next in July. July 16th is We Train the Wrong Things, a hard look at crisis workforce prep. And so until then, we hope that you have a great rest of the week, and we'll see you soon. Cheers.